3, 2, 1. How do you do, folks? Mike Hislop for Orlando Medical Institute TV. We are going to go over trauma systems and talk a little bit about mechanisms of injury associated with today's lecture. So stay tuned. It's going to be a two-part series. Let's jump right in. First and foremost, what is trauma? The ability to kind of predict what's wrong with somebody beforehand. Trauma is kind of easy diagnostically comparatively to, say, medical emergencies, certainly. It's always the primary cause of death, 1 to 44, because this is when folks believe they're still under warranty. Mechanics and biomechanics, right? The idea of what's this amount of force going to do to this portion of the body and how and why and how it acts. It's really going to help you manage your ability to kind of predict injury patterns associated with your patient. As we see here, an injury, a very vascular, dense organ like a spleen, like a liver, certainly can be negatively affected when you exude trauma on it. Obviously, it's not compressible, so it's going to burst. It's going to cause significant bleeding. Energy cannot be destroyed. It has to be dissipated and transferred through other things. The ability to see how that force was transferred from the front of the car, side of the car, depending on how that energy was transferred, gives you your ability to kind of predict what kinds of trauma we're looking at, whether it be these forms of energy, right? Mechanical, chemical, thermal, or heat energy, electrical energy, and certainly pressure waves, right? Associated with blast injuries, even with barometric energy. All of these are going to have different disease patterns or symptomology that we can kind of recognize in our patients' presentations. Biomechanics, that's how the physiology and the mechanism of living organs, how things relate to each other and how force is going to change that. Kinetics is all about motion, right? Speed, mass, direction of force, how the energy of motion is going to affect biomechanics and how it's going to affect physiology and potentially our outcomes. The ability for the body to disperse energy, obviously larger people disperse energy more easily than, say, smaller folks, which is why typically kids in trauma don't have the better outcomes, right? So it's about size, how big what you're hitting is, how big, but the biggest concept of all is always going to be speed in trauma. You'll have a formula, right? Speed squared over 1/2 velocity. So speed is twice as important as any other factor associated with how things happen. Did you go from very fast to very slow in a short amount of time versus a long amount of time? What body system or area was affected? It's going to go into that injury prediction. The duration and direction, the larger the force that dissipates, the more potential the injury is, which is why we can use those predictive patterns in trauma emergencies associated with alerts, i.e. you were thrown from the vehicle, that we have physiological proof that enough force was there to take something 200 odd pounds and throw it from the vehicle against its will. So obviously that is going to be one of those things where we have evidence that much force was there, so we can predict those injury patterns more easily. Blunt trauma, a little bit more difficult, right? It's a little more insidious. The ability to kind of affect that liver, affect that spleen under that rib cage, and how that's going to make our patient kind of predict what they might have going on, as far as even people that wear or don't wear seatbelts inappropriately. Impact resistance of the body has a part of bearing type of how tissue is going to be disrupted, right? Whether it be a stab wound, a low velocity, or a high velocity rifle, or a penetrating injury. All of these things are going to contain predictors as far as what's hit, what's likely affected. Obviously, we talked about liquid or blood-containing organs. They're dense, they're non-compressible, whereas hollow organs are compressible. What are all the hollow organs? And they're going to be, National Registry is very interested in you understanding the difference between a hollow versus solid organ. Solid organs tend to be highly vascular, so you're going to bleed a great deal. This is hemorrhagic shock and typically intra-abdominal or intrathoracic bleeding. Whereas those hollow organs, they typically contain what you should see as infection, right? Whether it be stool, urine, hydrochloric acid, they're always about that septic infection kind of a concept. Understanding mechanism, we pull up our windshield assessment, as it said in some textbooks. We're looking at this wreck and we're going to say, look, this is bad, right? Somebody should be significantly injured, if not dead, in a mechanism of injury like this. In which case we have to hang on to that mechanism and understand that it has no agenda. The body can lie to you physiologically with compensation. The mechanism can't lie to you, so it has to be a more reliable witness. And sometimes we undervalue that and filter a good patient presentation through that mechanism, and we feel confident where we should not. The mechanism will not lie to you, so we have to trust in it. A couple of different terminologies here. The velocity, obviously distance unit per time. That's speed, right? Acceleration, the rate of change, or deceleration. That's going to go in both fronts. Gravity, right? Depict things are going to move downward. It's going to pull towards the earth at a certain amount of page. There is a terminal velocity you can reach. But kinetic energy, right? That's mass divided by 2 times velocity squared, which screams to you, not for the math-oriented, velocity is extraordinarily important, where mass is by definition half as important. So it really comes down to, if there's one predominant factor, it's how fast. What was the speed? Speed of impact, speed of deceleration, speed at which things hit. Kinetic energy, right? The law of inertia. Things in motion tend to stay in motion unless acted upon by an equal or opposite force. So it's going to transfer this object and this object's energy of motion into another object, in this case, another vehicle. And we can see that crumple zone being affected. We can see the energy transfer, and we can predict where it went. And if your patient's sitting right in the pathway of all that energy going through, we have to know that obviously that's going to have a great impact as far as our injury predictions. Other factors dissipate how it clues, right? The vehicle's angle of impact, a glancing blow versus a head-on. Obviously, we know a rapid deceleration with a head-on, and you absorb all that force, obviously has worse outcomes. Differences in size of the 2 vehicles, a tractor-trailer versus the Yugo, we know who's not going to win. Restraint status, were they wearing their 3.5 point? Did they have, other supplemental? Did they have that airbag deployed? Were a lot of the engineering that now comes in some of the newer cars employed, right? When you see those NASCAR hits at very high speeds and the car seems to blow apart, that's to take all that energy and take it away from the driver, right? It's by design. A lot of those same design things are going, and those concepts are going into cars of design now. Law of conservation of energy. Energy cannot be neither created or destroyed, right? So it just simply keeps transferring different mediums, right, and passes from one to another. How it dissipates over time, kinetic energy, it transformed into mechanical energy. Mechanical energy is that energy of force and motion. And typically that's where those protective devices have to come back in. And hopefully people using them appropriately are having better outcomes, right? Newton's first law of motion, as I said, motion stays in motion unless acted upon by an equal or opposite force. The second law, force of an object exerted, produced its mass in time. So as much as it takes energy to push something, it also takes that same amount or equal opposite energy to stop something. So, and that's where we get our force is the mass times acceleration or deceleration, depending on how quickly you stop, right? It's not that long fall that gets you, it's that sudden stop at the end typically. Rapid deceleration, obviously tremendous forces. Right, your car hits it, you hit the car, the organs shift forward, so we have multiple different hits going on even within the same amount of force. Multisystem trauma, and this is the one that typically has the worst outcomes, right? I can teach you how to deal with an isolated head trauma, an isolated lung trauma, an isolated belly. But very often what we find is with that much energy, multiple systems are affected, right? So you have to be able to look at a single human being and literally triage systems within a single person as to what's the priority. And that's where our good primary assessment and our good recognition of mechanism comes in, so that we're able to prioritize what's the most important thing for our patient to keep them alive in the short term. Injuries, blunt trauma, obviously, they're insidious, right? If I had to pick, I mean, everybody would be penetrating trauma. It went in here, it came out there. Or it went in here and didn't come out there. But we have an injury pattern. We have a prediction. We have a site. We have something to look at. Very often, blunt trauma can be vague, right? It's the seatbelt. It's something blunt hit you, right? And certainly that's going to have a greater impact as far as how it works. Lots of phases of trauma. One, deceleration of the vehicle. You're going to come to that sudden stop. Deceleration of the occupant. Suddenly you come forward. As I said, now your organs are going to, phase 3, moving forward. Phase 4, now it's those additional or extra impacts that can be even multiple, especially think about a rollover, right? That entire phase can actually continue to repeat over and over. And that's why these typically have worse outcomes. Front end and certainly head-on impacts, we know getting dispatched right off the front end collision or a head-on collision, we know that these have bad outcomes. However, I'll note that most engineering and those safeties of those vehicles are protected from the front end, right? They're protected to make that force go around the driver rather than into the compartment. And very often they're responsible for people having good outcomes, even in situations where the mechanism's quite high. Common injuries, obviously, that rapid head injury, right, from you going forward. Or secondly, that deceleration injury, that's where you can have those great vessels and aortic tears, shearing of internal organs, the kidneys, spleen, liver, and or crush or compression injuries. Remember, you're going ahead 70 miles an hour and the airbags coming at you at 220, that's a big hit, right? And it's a multiple one. The up-over pathway versus underneath, obviously lower orthopedic injuries versus that head and neck trauma that typically goes with that up and over pathway. This is something we can predict. We can look at our windshield. We can say, where was the force? And very often those tib, fib, and ankle fractures are indicative of somebody taking that under pathway. Lateral side impacts. Lots of engineering companies are now working on lateral side impact airbags and these other things because we want to be protected from all sides, in a vehicle accident. But certainly remember, most of the engineering is going to be up front because we typically hit stuff going forward. Seat belts, lateral protection in lateral impacts or side impacts. Because they're designed to keep you from going forward and backward, not side to side, whereas you can have those lung injuries typically or orthopedic side injuries. Rear impacts, obviously, this guy lost because he picked a fight with a very large truck. And very often what you'll find is the person in that vehicle, that larger vehicle, likely has no injuries whatsoever because the amount of force was dissipated in a very large object versus that smaller vehicle typically lost. Hyperflexion, acute hyperflexion or hyperextension, typically those whiplash type of injuries. Rear impacts, typically best survivability, right? You're not going to have a ton of stuff. Rotational or quarter panel impacts, a lot of times you see a car doing this and you think, well, that's awful. But in truth, the greatest damage occurs like where the vehicle actually lost speed, right? Where at the end. Because in the spin, much like being in the eye of a storm, a lot of that energy is being dissipated, typically very often away from the patient. Rollovers and certainly anybody who left their vehicle, not of their own volition, certainly have these highest impact of bad outcomes or highest threshold of those injuries, obviously, because this is proof that much force was in that vehicle, and certainly we are softer and mushier than a lot of that stuff that's bent and broken, so it stands to reason we would have pretty significant injuries. Seatbelts, they stop the motion of the occupant. That's their job, right? They're supposed to be worn over that pelvic girdle, and typically we don't. We wear them right across our soft belly, right across that spleen and liver. So very often, an early depiction of one of those seatbelt signs or that ecchymosis in the pattern of a seatbelt kind of gives us an idea that there's probably, while we didn't have an ejection, that doesn't mean that this was completely benign, and we do have to really kind of surveil that belly pretty closely. Airbags. They have, when used as a supplemental to seatbelts restraint system, absolutely saved lives, no question about it. But that doesn't say that they're completely benign, right? They come at you with a great deal of force. It was a way that engineering's used the lesser of two evils, right? There's direct contact, certainly. There's chemicals in the airbag, that powdered stuff. Try to keep law enforcement from trying to put them out. It's not a fire, it's just powder. But it looks like smoke, and very often I've had several scenes where law enforcement will come out with an extinguisher thinking the patient compartment was on fire when that wasn't the case at all. Motorcycle crashes, they offer very little protection, right? You're exposed, in which case motorcycle wrecks of significant speed typically have bad outcomes for the recipients. Using helmets, using appropriate gear, using leathers, keeping away and helping with those orthopedic stuff can only do so much, but certainly will be more protective than, say, not doing that, right? Attention, deformity. What does the bike look like if it's completely destroyed? Was it side or front end damage? Did it skid for a long period of time and reduce a lot of that speed before the impact? Or was there no skid and they took the full speed of the impact? Look at those helmets, right? And we love the fact that a helmet can certainly be worn appropriately, help protect you from those head injuries, but it's also a depiction of how hard that thing hit, because you still have concussive force that can go into that helmet, even if it did its job. It didn't mean it made you benign and took away all risks, certainly. Head-on impact, right? So one of the most common, right? Something came out and you hit it, in which case you're going to go forward. You're likely to catch the handlebars across those bilateral femurs and get those orthopedic injuries, and because the rider's going to continue forward, right? Even though the bike may stop quite quickly. Angular, typically now you're talking about crush injuries, right, or left femurs, even if you laid the bike down. So they're predictive as far as those patterns and what we're going to likely see. Ejection, there's lots of people go back and forth saying, well, if you're launched off a bike that hit something, is it really an ejection? Arguably, yeah, opinion yes, opinion no. We're going to see this was the mechanism. This is how far this person traveled. This is how much force was there, and that's the most important factors to really kind of put together. If you're launched on the back out of the back of a pickup truck, is it truly an ejection? I would argue no, but it is what it is. If you traveled 30 feet, I think you're going to get that trauma alert criteria anyway, frankly. Do not remove the helmet unless it's necessary for airway protection, right? I get it. And if the idea that a portion of your patient is going to remain covered and unlooked at and unsurveilled, it makes me uneasy as well. But if it can't be managed, you have to get in that airway and then it's got to come out. But again, remember, this is a technique you learned back in EMT school and has to be employed, where typically one person holds C-spine and gets that manual blaze, where the other person widens and pulls it off. It has to be done by trained personnel. Done badly, it can actually do much more harm than good. So we have to be quite careful there. Pedestrian injuries, typically three predominant things, right? That first impact, the auto is going to boom, hits the bumper, right? This is basically auto versus ped. And whether it be a pediatric patient or adult patient, it just depends on where they hit, right? A little bit different in the sense that kids tend to look at what's going to hit them, where adults tend to look away. It kind of goes into our injury pattern. Second impact, you're getting hit over the hood. Did you go under? Did you go over? Again, that could be a tertiary impact if you have to land on the ground afterwards. Kids tend to get taken under because they're small, right? They don't tend to go that upper pathway. Look at the bumper and the pelvis and the femur, right? Because that's typically where they're going to hit, depending on where their height is, because that certainly has a great deal to do with where it hit them. If it hit them right in the chest plate, obviously your injury pattern is going to be quite difficult. And remember, them being top heavy, they're going to hit that head on the pavement. So all of those things are kind of in play. Fall from heights, calcaneal fractures bilaterally, the Don Juan fracture, as it were, the legendary Latin lover that would jump from the second story of probably some married lady's bedroom, I would think. Bilateral calcaneal fractures. Now that's that direct contact, right? So it's going to take that force and send it directly up into those trochanters on either side, and very often that femoral neck may in fact have fractures associated with, hey, what'd you land on? How high was it? What was the speed? Again, all those same variables. Low velocity versus high velocity in penetrating trauma. And this really comes down to a stab wound, right? Maybe the lowest penetrating trauma velocity versus that high-powered rifle, super high velocity. So we know speed equals the highest relativity in force. So typically a bullet flattens out, it's going to tumble, it's going to ricochet. A lot of them are designed to do maximum amount of soft tissue trauma and damage. So it really depends on, hey, caliber, speed, distance, and if it was in fact one of these horrible specialty bullets that potentially can cause more problems. This guy was hitchhiking. He wasn't, right? He wasn't. He was probably cleaning his gun. And we see a lot of these, right, where really not good technique and not safety precautions associated with it. United States, most common is firearms, right? We are the country of guns, right? Everybody's got one if they don't have 7, right? So they're out there, and because they're out there, we're going to see people shot accidentally, intentionally, and vice versa. It's just out there. Stab wounds, it turns out knives are readily available even to folks that don't own guns, in which case certainly stab wounds are out there as well. If it's going to impact CPR, take it out. If not, it stays in, right? Bulky dressing around that. And we can predict, hey, how long was the length of the blade? Trust me when I tell you, don't take it out, measure it, and put it back in. It's still a felony. But knives, again, often come in sets. Let's get one that's identical. We can predict. It's typically from the length of the hilt, we can almost always mathematically predict how long that knife is. But this should be removed in the surgical suite, where we can get in there and open the patient up and tamponade any vascular damage or something that may do a great deal of bleeding quickly. Otherwise, the patient's going to have a bad outcome and die, and we certainly don't want that. Again, gunshot wounds 101. Shotgun, close range, low velocity weapon. It's sporadic versus the high powered rifle. Velocity, right? Speed is everything. In which case, what kind of muzzle, what kind of we're not going to become firearm experts, and nor do you have to. You have to be able to rationally say this is an entrance wound, this is an exit wound. But as far as a lot of the other details, you get what you can, and use law enforcement as a resource on these things. Very often, while investigating crimes, they get actually quite adept at being able to either recover a gun and let you know what it was, or maybe help you with your pattern predictor as far as what it was and from how long, based on their investigation. Shotguns, again, they everything from non-lethal airbag little pellet things to small shot kind of pellets. all kinds of things, right? And they're going to do multiple projectiles at once. But a lot of times these are not going to be very deep because they're not very fast, in which case from medium range as a home defense weapon, you're going to really pepper somebody with this stuff and more likely to die of infection than acutely. Rifles, they single projectile, very high velocity, super high velocity. They spin for accuracy over distance, and that's the biggest maybe difference between these particular projectiles. Whereas handguns, 5-10 rounds typically. Some pistols can hold 17-18 rounds depending on what kind of mag you have in there, but accuracy is limited on these because these don't spin, right? It's just a very fast projectile, but typically much closer range weapons typically. Ballistics, that's a whole science in itself, right? The trajectory, the curve, the pathway of the bullet. People that get into specialties within law enforcement and or military and learn to be snipers, you're going to learn formulas on exactly distance, ratio, speed, height, weight. Everything gets put into typically now actually a computer that's going to help you actually zero in on your potential target, as it were. Automatic versus fully automatic, semi-automatic, depending on how many rounds per second can put out, and literally you can pepper a bullet with 100 rounds a minute, or more. In which case, how many gunshot wounds are out there? Know that if you're in an area where a lot of bullets came out a lot very fast, you may in fact have more than one patient. So have that in mind. When you find one, there could be more. Seriousness of the wound is, hey, what type you got shot at? Where did it hit you, right? Through and through in the arm is not likely to be lethal. It has to hit the brachial artery, and well, we know in short term you can put a tourniquet on and stop bleeding, but that's not the same in the torso, the abdomen, the chest, or certainly headshots. I mean, these are typically associated with bad outcomes because they die a lot, right? Deformity, tissue destruction is based on what? How dense is what it hit? How compressible, the missile velocity, how fast, and did it fragment, right? Fragmenting bullets or ones designed to create maximum destruction, typically they get the job done, and that's by design, right? They're designed to kill soft tissue. It crushes the tissue, creates a permanent cavity, so very often understand that when this bullet's going quite fast towards you, it actually has air in front of it that's being pushed. So just before it hits you, it literally creates a temporary cavity and then enters in behind that. And that would be that permanent pathway, that cavity that's created through cavitation and movement. And then did it stay intact, go through you like you were warm butter, or did it actually fragment based on, hey, how far away was it when it hit you? And very often that's the differentiation between the injury patterns. Exit wounds, typically if it's not medium range, if it's close range, you're going to have stippling or burning around the wound for people that maybe attempted suicide or got shot at very, very close range or against them. Exit wounds, you're going to see that it has that outward kind of a force and that stippling outward, and typically much more of a demonstrative wound a lot of times than even the entrance wound, which is typically quite pristine because the bullet's at higher velocity at that point, right? So it's going to have the ability to kind of create that cavitation pressure that's going to be there. Very often, and don't consider yourself a failure, you just can't figure out, hey, is this entrance, is that exit? Based on the amount of trauma, time, swelling that took place, and the amount of bleeding that takes place, all these are variables that can actually make it different. It's actually quite difficult sometimes to figure out. I had an entrance on the chest that also had an exit wound right next to it from the same bullet. It literally went in, bounced off the scapula, and came back out 2 inches later. I was completely in the weeds. I thought I had 2 entrances and no exits, right? So could that happen? Absolutely. Shotgun rounds, as we said, low velocity, mostly tissue destruction, bunch of just peppering. Infection's an issue, but as a home defense weapon, it's the one that's typically endorsed by law enforcement most often because it really just takes the I want to rob you and or fight you right out of a person typically. Powder charge, size and depth of the pellets, obviously there's ranges, and how long was it? Was it a long barrel shotgun, short, sawed off, whatever the case may be, depending on the dispersal and the length that you see there. And a lot of that has to do with that mechanism of injury that we can now predict. Try to obtain, hey, what was the weapon? What was the distance? What kind of bullets, right? That's the biggest three. Don't get into abandoning your patient's ABCs for that equipment, but understand that that's really good surveillance equipment a lot of times that we can get from law enforcement. They are, in fact, experts at that investigation. Is there powder residue, very close range versus entrance and exits? And very often that can tell us what went where and why, and maybe be able to piece a little bit together as far as the mechanism, right? Remember, don't get into doing criminal investigations on scenes like this. It's not your job. That's a whole different genre and profession. So stay within ours and keep people alive. That's the biggest key, especially in early trauma recognition. All right, that has been part 1 of Trauma Systems, Mechanisms of Injury. Please return for part 2, more about understanding what we're supposed to see. We have to look at things with different eyes sometimes in trauma. This is Mike Hislop signing off.